it's gone like this. I mean, it used to be when I first started doing it about 7 years ago, it was kind of considered fringe therapy and kind of the treatment of last resort and kind of witchcraft, you know, that you're doing this. But now it's really, over the past couple of years, become more and more acceptable to the point where it's recommended by the American College of Gastroenterology treatment guidelines for treatment of recurrent C. diff. And it's essentially, we know C. diff results from disruption of those good beneficial flora. It's essentially taking good, healthy bacterial species from a donor who hasn't been recently treated with antibiotics and who is clinically well, and transferring those bacteria to the patient, where they then engraft and colonize and restore that good bacterial balance and kind of crowding out the C. diff again. And it's highly effective, about 90% or more, in stopping these recurrences of C. diff. Traditionally been given by a couple of different routes. You know, gastroenterologists, we tend to favor the lower, you know, either colonoscopy or sigmoidoscopy. Others have demonstrated it works as well by giving it through a nasogastric tube or a nasoduodenal tube. So they put the tube down and instill like a liquid solution of feces. The cheapest method of all is probably giving it just by plain old enema, which a group in Canada has demonstrated, you know, it's effectively, you know, given that way. And the best way to give it may depend on, you know, individual patients and what's going on with the individual patient. Certainly we're not going to be just putting whole stool in people forever. There's recently been efforts to try to kind of modify and number one, encapsulate it, where people could just take capsules. And there's a couple of papers where they've literally just taken fresh stool and encapsulated it. Usually you have to freeze that because the liquid stool will kind of make the gel caps kind of disintegrate, so you have to usually keep them frozen, but that's been effective. There's a company which I've actually done consulting and research for, in full disclosure, Series Health, who's actually going to be starting a phase 3 trial of their product, which is an encapsulated form of sort of a distilled fecal transplant. They've essentially treated human stool to eliminate all the other bacteria except what they think are the effective ingredients in a fecal transplant, which are clostridial spores of, you know, non-C. diff. They treat patients with those spores. They recently completed a phase 1-2 study of 30 patients, and 29 of those patients met the 8-week endpoint C. diff free after taking the oral formulation. So hopefully we'll be seeing more and more things like that coming down the pipeline. There are home transplants being done. I cannot advocate for those. There's actually a YouTube video that's had over 45,000 views where a guy shows you how to do a home fecal transplant. So home transplants are being done. I think people have this hope that, hey, it worked so good for C. diff, maybe it works for other ailments, other GI issues. There's great interest in studying it in inflammatory bowel disease, obesity and the metabolic syndrome, autoimmune diseases, autism. I've had patients, families contact me, you know, in desperation, you know, wanting a fecal transplant. At this point, the US FDA really defines fecal transplant as a drug, and as such, it's not legal for a physician to administer fecal transplant in this country unless it's for recurrent C. difficile. So they've allowed that. They've allowed that, you know, this, they call it enforcement discretion. They're not going to enforce their policy as long as you're doing it for patients with recurrent C. diff, but you can't run around and do it for anything else. And these home transplants, really, I mean, there's this danger that you could have maybe an infection transmitted easier because you're not doing donor screening. You know, when the patients, we do use family members as donors all the time, but they have to go through a questionnaire to make sure that they're healthy and clean living and not at risk for transmitting infection. And they go through a whole battery of serologic and stool testing to make sure that they're not going to transmit an infection and make the person sicker or give them something else. There is a nonprofit group who right here in Boston, outside of Boston, called Open Biome. And they're essentially, they've centralized that whole process of donor identification and screening and developed a stool bank. And for their costs, which at this point is $250 a dose, they will ship frozen stool, which can either be thawed and used that day or kept in just a standard medical freezer for, you know, up to 6 months. And then when you need a dose to treat a patient, it can be used without having to go through that finding a donor. They've really done a good job of being very strict with their donor identification and screening policies. They're also very interested in quality control. They keep an aliquot of every dose that they send out for 30 days prior to sending it out, and they make the donors get retested again. So the donors are actually tested twice to make sure they're not in the window period for some infection. They are interested in working with researchers and supplying stool to people who are interested in studying fecal transplant for C. diff and other things. At this point, any practitioner can administer a fecal transplant. You don't need to be a gastroenterologist. Obviously, if you do it by colonoscopy, you need to be a gastroenterologist. But other doctors can give it by enema. A nurse could give it by enema, or nasogastric or nasoduodenal tube. The one caveat to that, and I'll say that we submitted a study that we did at our center over an 18-month period of the patients that were referred to me for a fecal transplant for recurrent C. diff, and we found 25% of them actually did not have recurrent C. diff. And I found a whole spectrum of alternate diagnoses, and these people had been seen by specialists and referred to me. So there's a misdiagnosis sometimes, and things to think about: inflammatory bowel disease. I met a woman who had Crohn's disease and was treated over and over and over for C. diff, wasn't getting better, did a colonoscopy, and she actually had fistulizing Crohn's disease. I've seen chronic pancreatitis, factitious diarrhea, where at least in 3 people, they were sort of making it up and coming into the hospital and getting pain meds and other things, and they were just colonized with C. diff. So their test would be positive and they would get treated, but they really weren't having diarrhea. So put your thinking caps on. When you're seeing one of these patients, just because they've had a diagnosis of C. diff doesn't mean that the reason that they have diarrhea right now is C. diff. It could be just because of some of the limits with the current testing we have. It can identify that C. diff is there, but it doesn't always identify and tell you C. diff is causing the problem. There could be something else going on too. So if there's any question, referral to a gastroenterologist with expertise in the area is helpful, I think.